We often hear from patients that they try to take their medication as soon as they feel a migraine attack coming, but we know that's not always possible. Many of our patients experience nausea, vomiting, or other gastrointestinal issues with migraine. Then we have patients who say they don't always get relief from their oral medications, or the relief doesn't last. Additionally, patients taking anti-CGRP preventive therapy still experience breakthrough attacks, and many times these acute attacks are treated with oral anti-CGRP treatments. With all the limitations of oral treatments, dosing window, GI complications, relief that doesn't last, similar mechanisms of action as preventive, here's why I would consider treating with Trudhesa. First of all, the long-term proven efficacy of the molecule dihydroergotamine mesylate, DHE. If you recall, across 4 different clinical trials of traditional DHE nasal spray, patients experienced relief rates ranging from 47% to 70% at 4 hours. Then there's the result of the Trudhesa Phase 3 safety study. Trudhesa exhibited a well-tolerated safety profile with no cardiac TEAEs and no clinically significant ECG interpretations, no treatment-emergent adverse events associated with abnormal ECG, and only 0.6% of doses resulting in nausea, with more than 6,000 doses administered during the 52-week trial. Patients with a history of cardiovascular events or presenting with significant risk factors for cardiovascular disease were excluded from the study. The most common local irritative symptoms were the typical treatment-emergent adverse events reported with nasally administered products, including nasopharyngitis at 21% and rhinitis at 19%. Exploratory efficacy endpoints demonstrated rapid, consistent, sustained relief with Trudhesa with no dosing window. 38% of patients reported pain freedom at 2 hours, and of those patients, 93% remained pain-free after 24 hours and 86% at 48 hours. Patients also reported experiencing pain freedom despite taking Trudhesa late into the migraine attack. The percentage of patients who were pain-free at 2 hours post-dose was similar whether patients took Trudhesa within 2 hours of migraine attack onset or from 2 to 4 hours after attack onset, at 39.3% and 39.4% respectively. Even among those who took Trudhesa more than 4 hours after attack onset, 30.9% were pain-free at 2 hours post-dose. Additionally, of the 4,257 migraine attacks treated during the 24-week trial, 85% treated with Trudhesa did not require rescue medication. If you have patients who struggle with dosing windows, GI complications, relief that doesn't last, or have breakthroughs on preventive medications, what are you offering them? It's time to consider Trudhesa.
Indication and important safety information. Indication. Trudhesa is an ergotamine derivative indicated for the acute treatment of migraine with or without aura in adults. Warning. Peripheral ischemia following co-administration with potent CYP3A4 inhibitors. Serious and/or life-threatening peripheral ischemia has been associated with the co-administration of dihydroergotamine with strong CYP3A4 inhibitors. Because CYP3A4 inhibition elevates the serum levels of dihydroergotamine, the risk for vasospasm leading to cerebral ischemia and/or ischemia of the extremities is increased. Hence, concomitant use of Trudhesa with strong CYP3A4 inhibitors is contraindicated. Limitations of use. Trudhesa is not indicated for the preventive treatment of migraine or for the management of hemiplegic or basilar migraine. Contraindications. Trudhesa is not recommended in patients with concomitant use of strong CYP3A4 inhibitors, such as protease inhibitors, for example, ritonavir, nelfinavir, or indinavir, and macrolide antibiotics, for example, erythromycin or clarithromycin. Ischemic heart disease or coronary artery vasospasm, uncontrolled hypertension, known peripheral arterial diseases, sepsis, following vascular surgery, or severe hepatic or renal impairment, hypersensitivity to ergot alkaloids, concomitant use of other 5-HT1 agonists, for example, sumatriptan, or ergotamine-containing or ergot-type medications within 24 hours. Concomitant use of peripheral and central vasoconstrictors. Warnings and precautions. Trudhesa may cause cardiac events. Cardiac events in patients with risk factors of coronary artery diseases. Consider administration of the first dose of Trudhesa under medical supervision, including the use of an electrocardiogram. Cerebrovascular events. Cerebrovascular events, for example, cerebral hemorrhage, subarachnoid hemorrhage, and stroke, have been reported, particularly with dihydroergotamine mesylate injection. Vasospasm, elevated blood pressure. Dihydroergotamine may cause vasospasm or elevation in blood pressure. Fibrotic complications. Rare cases have been reported following prolonged daily use of dihydroergotamine mesylate. Administration of Trudhesa should not exceed the dosing guidelines or be used for chronic daily administration. Medication overuse headache. Detoxification may be necessary. Preterm labor. Advise pregnant women of the risk. Local irritation. Local irritation has been reported following administration of Trudhesa. Most common adverse reactions. Most common adverse reactions, incidence greater than 1%, were rhinitis, nausea, altered sense of taste, application site reactions, dizziness, vomiting, somnolence, pharyngitis, and diarrhea. Use in special populations. Pregnancy. Available data from published literature indicate an increased risk of preterm delivery with Trudhesa use during pregnancy. Lactation. Patients should not breastfeed during treatment with Trudhesa and for 3 days after the last dose. Please see the Trudhesa full prescribing information, including boxed warning and medication guide. The risk information provided here is not comprehensive. The FDA-approved product labeling can be found at www.trudhesahcp.com or 1-800-555-DRUG. You can also call 1-833-TRUDHESA, 1-833-878-3437 for additional information.